So we're going to talk about autoimmune hepatitis and its variants, just continuing on the theme that David so nicely laid out. So we're going to talk about a disease that's been around for a long time. It was actually, if you play any Trivia Pursuit or Jeopardy and they ask what is the first treatable disease that hepatologists had, the answer is what is autoimmune hepatitis. And so it's a chronic inflammatory disorder, and it is characterized by circulating autoantibodies and a high globulin level. It's been around for and recognized for quite some time, not quite as long as primary biliary cholangitis. And the first International Autoimmune Hepatitis Group recommended the term autoimmune hepatitis in 1992. The most recent updates for the AASLD are 2010, and EASL, which I have to confess the Europeans were a little ahead of us, were 2015. And it's important that we distinguish this from other forms of liver disease because the treatment is unique. So it's been classically described in women. It affects people of all ages. And about 100 to 200,000 persons in the United States have this. It represents actually a fair number of transplants, 6%. And the reason for this is because it often has an insidious onset. So young people get this, and they actually have significant necroinflammatory activity, and they don't know it. So it's important that when you find elevated liver tests, that you assess for this particular disorder. While originally described in Caucasians, it occurs in all races, and men certainly get this as well. So here are the classifications of autoimmune. So you used to have 3 types, and we have now narrowed it down to 2 because the soluble liver antigen turned out to be actually just enrolled into type 1 autoimmune hepatitis. But you have type 1 and you have type 2 autoimmune hepatitis, and we're going to go through these. The main differences are in type 2, you have generally females, and generally they're a bit younger, and also the presentation is a bit more severe. Also, other differences in type 1, you can get people off of treatment, which we'll go over at the end of the talk, but it is a bit more problematic with type 2. It's much harder to taper individuals off of this. So now let's transition to type 1 autoimmune hepatitis. And so this is the most common type of autoimmune hepatitis in the US and Europe. The classic 2 antibodies that we see with this are the anti-nuclear and the smooth muscle antibodies. Now, when you're reviewing your liver test, abnormality evaluations, and labs in the clinic, you often see low titer ANAs, and they can be very frustrating. You have to correlate it with other features. So, for instance, we see people who are referred, and you're fairly convinced that they have non-alcoholic fatty liver disease. The ANA comes back 1 to 20, 1 to 40. It's likely that's non-alcoholic fatty liver disease, and the ANA is an innocent bystander. Low-level smooth muscles are also found very, very frequently. Again, 70% are women, and typically younger, less than 40 years, and there is also an association with other concurrent autoimmune diseases, particularly thyroid disease, some rheumatologic disorders, and ulcerative colitis certainly occurs. As I said earlier, there is an abrupt onset of symptoms in about 40% of individuals, and 30% of patients who you will see in the clinic presenting with autoimmune hepatitis will actually present with cirrhosis. Again, this is an indolent, aggressive subclinical stage. They may have had it for 10 years, and without symptoms, without routine liver chemistries, this would have never been detected. Finally, there is a rare but very real presentation of acute fulminant autoimmune hepatitis. This is where they present very dramatically. There is often, in addition to bridging necrosis, this is a disorder where you will actually see collapse. And whether or not you can rescue them with steroids is somewhat tenuous. We usually, in the fulminant autoimmunes that we identify, we usually try intravenous methylprednisolone, but we evaluate for liver transplant and as our parachute or our backup. So you have a few more slides in your presentation. Some of them were a little bit dense, and so for the end of the afternoon, I decided that some of them will be hidden, but they're all in your syllabus here. The ANA and smooth muscle, they're not disease specific. or are they pathogenic? The ANA reacts with multiple nuclear antigens, and sometimes you order an ANA and you can get a dizzying array of patterns back. Sometimes it's against the histones, centromere, et cetera, the pattern doesn't matter. That is the pattern of nuclear immunofluorescence. None of these matter. What matters is the ANA titer. And the same thing is true of smooth muscle antibodies. It reacts against actin and non-actin components of the cell. And again, it is the target of the antibody does not matter. Now, type 2 is a bit different. This is typically a disease of children. So who here has seen an LKM positive autoimmune hepatitis? And I know in the front row, Mitch and Mark and Catherine and Dave. Who else? Anyone else seen type 2 autoimmune hepatitis? They're quite uncommon, typically pediatric, but every now and then you see one. It's about 4% of North American adults. And if you believe they have autoimmune, this is the one immune marker that I find in the clinic doesn't always routinely get ordered. And so if you can't explain an elevated ALT, please send this one as well. It's more common, by the way, in Europe. And whereas there has not been a target autoantigen identified for type 1 autoimmune hepatitis, the target autoantigen for type 2 has been well described, and it's one of the cytochrome P450 enzymes, which is CYP2D6, which is an important drug metabolizing enzyme. While this is a more aggressive therapy, it actually, when you place them on therapy, they seem to respond as well. Unfortunately, they seem to relapse more than type 1, but the initial response is fine. And again, this liver-kidney microsomal antibody, the assay, it reacts against the proximal tubules of the mouse kidney and cytoplasm of the murine liver. And again, very interestingly, 1/4 of patients with immune hepatitis and autoimmune antibodies actually have, because of cross-reactivity, anti-LKM1 antibodies. So sometimes you'll see a positive AMA and you say, my God, this is autoimmune hepatitis when you get the biopsy, and these individuals may actually just have cross-reactivity. It's kind of interesting. There are immune overlap syndromes as well, and these immune overlap syndromes can be very complicated to try to interpret. One of the aspects that will help is in your practices where you are, get to know your pathologist. You should friend them, do whatever you can, the ones that know how to read liver biopsies. This is very important. Primary biliary cholangitis on a biopsy will have a small or mild amount of interface hepatitis. Inexperienced pathologists or pathologists that don't do a lot of reading of liver biopsies may say, hey, there's primary biliary cholangitis here, but there's also autoimmune. And again, you need to look at your serologies. You need to be sure, because the corticosteroids that we use for autoimmune hepatitis, obviously we don't want to be using these long term if we have diagnosed primary biliary cholangitis. So autoimmune hepatitis and primary biliary cholangitis really do overlap 5 to 10% of the time. But what you want to be looking for is, and not only the portal tract granulomas, which you don't always see, unfortunately. In fact, it's not classic. When you see it, it's helpful, but when it's not there, that doesn't exclude primary biliary cholangitis. But you want to see duct destruction. And for the autoimmune part, you really want to see an interface hepatitis, and not just a little bit of piecemeal necrosis, which we see with PBC. Autoimmune hepatitis and primary sclerosing cholangitis, we're going to talk about PSC, or primary sclerosing cholangitis, at the end of this lecture. But again, these coexist also, and you will need a liver biopsy as well as imaging to make this diagnosis. Some of these diagnoses cross over. That is, most criteria fit one diagnosis and there are some features of the other, and that's most common. However, there are true overlaps that do occur. So, for instance, if you have primary biliary cholangitis, duct destruction, T cells destroying the intralobular bile ducts, and you have bridging necrosis, well, then you really have both. And then you have to look at the liver chemistries and the clinical presentation and decide which is the driving presentation. You typically try to treat one first, get that under control, and treat the other one over time. Also, autoimmune hepatitis And hepatitis C also historically presented concomitantly. In the era of interferon, this was really quite problematic. However, now in the direct-acting antiviral agent era, it's actually quite straightforward. You treat the hepatitis C. That usually takes 8 to 12 weeks, and then you can treat any autoimmune hepatitis that's present. Finally, drug-induced autoimmune hepatitis is becoming also increasingly recognized. There's a very complicated relationship between drug-induced liver injury and autoimmune disease in that the drug-induced liver injury often promotes, by generation of this toxic phase 2 metabolite, an immunoallergic component which really looks quite a bit like autoimmune hepatitis. And we often see patterns of hepatic injury with high AST, high ALT, and high globulin that is in relationship to a recent drug exposure. And oftentimes you remove the drug, things get better. Oftentimes they don't. Also, there are other immune disorders which are triggered. So, for instance, 2 drugs which are really classic for triggering an autoimmune type hepatitis are nitrofurantoin, which is used very commonly, as you know, for urinary tract infections, chronic suppression, and is surprisingly not well recognized by urologists, who I think actually prescribe this more than anyone else. And then minocycline, which is used for acne, particularly in young women. If you see elevated liver tests in young women taking therapies for acne, it's usually minocycline. These are really the ones that are quite classic. And if you pick this up, you'll look great in front of the patient. They'll be forever grateful. So what's the pathogenesis? There are 2 mechanisms of liver cell injury that have been suggested. There's a cell-mediated cytotoxicity. These are the cytotoxic T lymphocytes that mediate liver cell destruction. And there's also an antibody-dependent cytotoxicity, which is associated with the production of IgG by plasma cells. And again, this is part of the reason on a liver biopsy, while plasma cells aren't absolutely necessary for a diagnosis, it's very reassuring when you see lots of them there. And what you do is these plasma cells secrete antibodies, and these are then aggregates are targeted by Fc receptors of their natural killer cells, which leads to cell death. So the pathogenesis is complicated. We have triggers. Nobody knows all of the triggers with autoimmune, but certainly drugs. I've listed a few here. Viruses, including here hepatitis. So, for instance, acute hepatitis A is well known to trigger acute autoimmune hepatitis, but it's not the only hepatotropic virus that's been mediated. There are certainly genetic predispositions. HLA, DR3, and DR4 are well known to be associated with autoimmune hepatitis and, again, our liver cell injury. Here are the simplified diagnostic criteria for the International Autoimmune Group, and you can see here you want a titer of ANA or smooth muscle antibody that's greater than 1 to 40, and then you get more points if it's greater than 1 to 80. If you have LKM1 or if you have the soluble liver antigen or liver pancreas of any type, the titer goes up. You would like to see a higher than normal globulin level, and you really need a liver biopsy. And in autoimmune, it's one of the disorders where I really try to go to great lengths to get a liver biopsy. I think we're getting to the point where liver biopsy is not so important. For autoimmune hepatitis, actually, it's really important, and you don't want viral hepatitis present. Particularly chronic hepatitis B, which is easily assessed by serologies, is a disorder you absolutely need to make sure is not present, because histologically they're going to look very similar with a rate of inflammation, though you should be able to pick this up with other features. So what's the clinical presentation? So it is absence of symptoms, which is why 30% present with cirrhosis. There's also discovered they can just incidentally, they get a comprehensive metabolic profile, and their ALT is high, and it's typically not just minimally elevated. The ALT levels are higher with autoimmune hepatitis, and again, sometimes you present with a severe acute hepatitis. And when you have fulminant liver failure, lower albumins, higher bilirubins can differentiate the presentation. And there's also a very unique presentation of zone 3 necrosis that we see with acute autoimmune hepatitis as well. So again, here is what you would see on a liver biopsy. So, at an angle again. So this is the portal tract here, and that big white thing is the portal venule. And on a liver biopsy, you don't need to be experts in this, but just when looking at liver biopsies, remember the following: blue is bad, and when you see blue, it's not good. So these are all lymphocytes and plasma cells here. I apologize for the angle here and here. And this is zone 1, and this is what we call bridging necrosis. It's very active hepatitis. And even a pathologist that is not very experienced in reading liver, if they describe a very brisk inflammation, you need to be thinking this patient has autoimmune hepatitis. And again, at an angle, I'm sorry, this is going to be too challenging for me to show accurately, but you're going to have to trust my words when I tell you here. There are blue cells here that look like Ferris wheels in here. Those are the plasma cells that are secreting the antibodies. They're mixed in here. And again, you absolutely don't have to have lots of plasma cells, but it's much more reassuring for the diagnosis. And then finally here in an acute presentation, this is the central vein. So this is the vein here that drains into the hepatic veins. So the portal tract is where the hepatic artery and portal venule are, along with the bile duct. The central vein is after the blood comes here, diffuses through the sinusoids to the central vein. And you see this very unique inflammation around the central vein that's also typically seen with an acute presentation of autoimmune hepatitis. So who do we treat after you've assessed them? So there are guidelines have come up with both absolute and relative indications for treatment, as well as indications for no treatment. So let's go through them. If there's an acute onset or fulminant autoimmune hepatitis, then you should offer them treatment. If it's truly a fulminant, that needs to be done in context with your friendly neighborhood transplant center, because many of these acute autoimmunes are young. And so you, as I always like to say, if you have somebody who's young and autoimmune, you err on the side of life. Get them to a transplant center, and they will manage them and give the corticosteroids while evaluating for emergent transplant. Typically, if the AST and ALT are greater than 5 times the upper limit of normal, with a globulin 2 times the upper limit of normal, and if you have histology that your pathologist says, yes, there's bridging necrosis or multilobular necrosis, which I showed you in the first panel on the prior slide, then these are absolute indications. What are relative mild symptoms? AST and ALT lower than 5, that is below 5 to 10 times the upper limit of normal. If I'm convinced, I still treat those individuals. There was an earlier era, and there was a wonderful hepatologist at Mayo Clinic, Albert Shaya, who used to write extensively that these mild disorders don't quite progress over time, but actually longer follow-up, they actually do. And so so I think many of us are now treating these individuals, even if their liver tests are just 5 times the upper limit of normal. And again, without fibrosis, I still tend to err on treating them, but it's relative. Sometimes someone will present with cirrhosis. There'll be a very high ANA, and you'll decide the AST and ALT are normal, and you'll decide, wow, this is actually a perhaps burnt-out autoimmune hepatitis. Then sometimes if the ANA is very high, I biopsy them. The ALT and AST don't always go up to high levels in autoimmune hepatitis, and sometimes you will actually see bridging necrosis even though the AST and ALT are minimally elevated. And actually, that's actually an absolute indication. But if you have an inactive cirrhosis, that is, you biopsy, there's a tiny portal infiltrate, no piecemeal necrosis, you tell the patient, yeah, you probably did have autoimmune hepatitis, and you don't need to treat those individuals if you don't see inflammation. What are the therapies? Well, we typically use prednisone and azathioprine. Excuse me. And typically, you can use monotherapy with high prednisone, 60 milligrams, or you can taper and add azathioprine, which I like to do because everybody hates prednisone after the first few days. You know, patients will come in, they've been fatigued. You start the initial prednisone, they come back after a week, they tell me I cleaned my entire house, I did all the laundry, my husband's overjoyed with me, or my wife's overjoyed with me. After 3 weeks on those high-dose steroids, they're snarling at you because of all of the side effects that have settled in. And so you try and rapidly taper. But the key here is to make sure that you don't taper too rapidly, because what can happen is you'll bring the ALT down. You don't want to taper till you get the ALT into the normal range. You can also use, and then we add azathioprine, typically at a dose of 50 milligrams, but you can taper it up to 1 to 2 milligrams per kilogram. That's the European algorithm. Some people really dislike steroids, so we have another steroid steroid that goes through first pass effect budesonide, which actually works. It's a little bit less potent than prednisone. My big complaint about this one is that even the generic is incredibly expensive, and this is one where your patient satisfaction score may suffer when they get the bill and they go to the pharmacy and try to get 9 milligrams of budesonide filled with your pharmacist. This is a very expensive medicine, even though it is actually a generic is available. And so, but certainly 9 milligrams, which is 3 milligrams TID with prednisone, is another type of therapy. For maintenance, prednisone and azathioprine, I myself try and taper the steroids. I follow the European protocol, and I try to get people off steroids entirely slowly. You start tapering again once the ALT is normal, and that may take several months. So a very common mistake people make is they treat autoimmune hepatitis, the ALT gets down to 50, 60, and it was 300, 400. They say, great, I'm going to taper the steroids, and what happens? The ALT goes back up. You have to wait, and you have to make sure that you start the azathioprine. I typically like to start the azathioprine after making sure they tolerate the steroids. And people enter remission after 2/3 of the time within 18 months, and you typically can try and taper these individuals as well. What are the endpoints? Well, normalization of AST and ALT and globulin. You have to treat, typically I treat for 2 years, and then you can taper and monitor liver tests. Some people do fail, and you have to retreat them. Liver biopsy is actually the best way, and I encourage everyone with autoimmune to get a biopsy before and then after, because if you see activity in the portal tract after you've treated them, their risk of relapse is extremely high, and I actually tell them don't even bother because their risk is so high to relapse. And you just have to try and keep them, I try and keep these individuals on azathioprine. Some people fail to respond. We typically use our other immunosuppressives, and I particularly like mycophenolate. You can also use Myfortic. You can use your calcineurin inhibitors, ursodiol. All of these are reasonable choices. If you keep failing, best to send them to a hepatologist who is experienced in this. Liver transplant works. You have to use a little bit more immunosuppression. I, again, try and keep people off corticosteroids, but more likely they're going to need more immunosuppression. But certainly this works and is an effective therapy. When you relapse, you can retreat, and most people do. And again, once you biopsy them, if everything looks quiescent on biopsy, I typically check a hepatic panel every 2 months for the first 6 months, and every 3 to 4 months, because there's about a 50% chance of relapse, even with a quiescent-looking biopsy. And again, you can either retreat with the same regimen and extend the duration, or keep them on a therapy indefinitely. Once you relapse twice, I'm done. And I just tell people, sorry, it's not in the cards for you. PSC, just a few minutes on this. This is a sister to primary biliary cholangitis that David very nicely delineated, a chronic cholestatic disease that progresses to cirrhosis. And it's a macroscopic obliterative fibrosis of the intra and extra hepatic bile ducts, found commonly in association with ulcerative colitis and also Crohn's colitis as well, suggesting there's probably some common antigen on the colonic mucosa and the biliary epithelial surface that the immune system is targeting. The pathogenesis is unknown, but it's almost assuredly autoimmune. And there are classifications, so you typically diagnose it with imaging. ERCP for years, but our MRCPs are quite good now. And you can have both small and large ducts that are there, and you diagnose this macroscopically. There is this small duct PSC where the MRCP is normal, and you just get this onion skinning. You'll still see PSC type changes in the liver biopsy, and it's only the small ducts. And these individuals also have a type of PSC, and they also have a risk of cholangiocarcinoma, just like large duct PSC, but it's lower. And again, there's an overlap we discussed. Here's what it looks like, and you can see here the beading is shown here very nicely, both on an ERCP and an MRCP. And as I've said, the ERCP has been supplanted by MRCP. The resolution is really quite good. Nobody knows the pathogenesis. It is an interaction between genetic factors as well as the environment. Likely the microbiome has a lot to do with this, but nobody knows for sure. This is an area of really intense research. There is also no effective therapy. People, and we can discuss this, use ursodiol because it improves liver enzymes. The Europeans left the door open as an option. And I will tell you, if there are people with this disorder, I still give ursodiol. High-dose ursodiol was studied, and it turns out to be deleterious. And like I said, the AASLD doesn't have it. The EASL guidelines leaves the door open for you. And again, if you have bacterial cholangitis because of these strictures over time and you keep getting bacteremic, regardless of your stage of fibrosis, that's an indication to go to transplantation. These individuals are at high risk for cholangiocarcinoma. There are some guidelines that recommend annual imaging to screen for cholangiocarcinoma. I urge you to do it. And again, the guidelines give some flexibility. I would do it, and we do an MRCP annually, and if you have cirrhosis, you're getting an ultrasound because they can still get hepatocellular cancer as well. And I like doing the CA19-9 also twice per year. There are other complications, including the cholangitis. There's a higher risk of gallbladder polyps with this. And again, there is also, if you have inflammatory bowel disease, your risk of colon cancer with PSC is higher. You need annual surveillance colonoscopies. And if you have inflammatory bowel disease, then you obviously getting the colonoscopies. If you don't, because the majority of individuals with PSC do have inflammatory bowel disease, you need a colonoscopy in your PSC patients with biopsies to look for occult inflammatory bowel disease every 5 years. You have all the complications that you had with primary biliary cholangitis, metabolic bone disease as well, and so therefore you need to supplement your fat-soluble vitamins just like you do in primary biliary cholangitis. And as I said, there's a higher risk of gallbladder polyps in PSC, and these polyps can turn into cancer, and the thresholds for cholecystectomy are much lower with PSC. I've already talked to you about the cholangiocarcinoma risk. It's 20% lifetime, and again, this used to be a uniformly fatal disease. Extrahepatic cholangiocarcinomas can now be treated at select transplant centers, though everything has to go correctly. So many of these individuals, unlike HCC, drop out because of disease progression. And this is much higher rates than with hepatocellular cancer. So in summary, autoimmune hepatitis occurs predominantly in females, and there are other autoimmune diseases associated with this. Treatment is typically corticosteroids and azathioprine. Most people will respond to therapy. For a first episode, you try and treat and taper off after a few years, but the relapse rates are around 50%. There are lots of good therapies, including some novel agents that are being studied. For primary sclerosing cholangitis, the differential includes primary biliary cholangitis, drug-induced. There are a variety of other things you have to consider, but the MRCP typically helps us. The complications, cholangitis, biliary tract stone disease, cholangiocarcinoma, all have to be monitored. As we discussed, there's no effective medical therapy. Ursodiol is used, and high-dose ursodiol is deleterious. Liver transplant is the best treatment for this, but even with liver transplant, just like with autoimmune hepatitis, PSC seems to recur post-transplant, probably anywhere from 20, depending on the series, 20% to 50% of cases can recur with this as well. And this is probably, in my opinion, the one disease, PSC, that we need the most help, because young people get this, particularly young males, and we need better help with this particular disorder. There are trials, fortunately, now looking at a variety of novel agents for this, and I sincerely hope that we make more progress.